echo session. It's very sad, but we're excited to be able to bring you some great content and a great case presentation. So we're going to start this morning with Anne Marie Olson Hayward, who is the REAP Director with Seacoast Mental Health Center. And then we'll be moving to Mary Val Palumbo, who's a Professor and Director of Interprofessional Education at the University of Vermont College of Nursing and Health Sciences. So I'm going to turn things over to you, Anne Marie.
Well, actually, it's Mary Val. We were decided I would go first, so I'm all set, ready to go.
Sorry about that.
That's okay. So what I'm going to talk about is a lovely sabbatical research project I had in New Zealand. Hoping my internet will stay connected, and I'd like to acknowledge my collaborators. Elisa Vodier is a DNP graduate that was helpful in our smart phrase that you'll see. Betty Ramber is a policy expert. Lori McKenna is a social worker. So the last two and I went to New Zealand, and the purpose really was, let's see if I can go on here. The learning objectives for today are really to illustrate the New Zealand health pathway, cognitive impairment and dementia, for cognitive impairment and dementia, and detail the role of the primary care providers, and also gain familiarity with the use of a smart phrase for primary care diagnosing dementia. So just a little background, we went in search of an international exemplar and found New Zealand had some policy around dementia that we want to look into. We traveled there, studied it, and hoping to bring back some lessons learned. So we mostly were in Wellington and Auckland. It was a qualitative descriptive study with interviews. We focused on 20 primary care offices and the Ministry of Health, and ended up interviewing 5 GPs, they call them down there, 2 nurse practitioners, 5 nurses, 1 psychogeriatrician, 2 case managers, 4 social workers, 2 family carers, and 4 employees of the New Zealand Ministry of Health. And this is our illustration, so I'm going to walk you through this. In New Zealand, a common word for a family is wanu, and that really encompasses more than just the nuclear family, but a lot of the community as well. They're a country rich in cultural heritage, and that is seen throughout their society. So here's a little wanu surrounded by the Ministry of Health, specialists, PTOT, RNs, social workers, and the GP. And it was really the Ministry of Health that started this national standards for dementia care, and focused on an early diagnosis in primary care using the MOCA, suggesting lab tests, giving guidance around history, and using this inter-ray assessment, which is really about functioning in the home. The Health Ministry really supported this project with finances, social software, and electronic health record support, and access to primary care. They really did a good job with education. They had a lot of nurses that were dementia educators that promulgated this pathway. And we really found that they had some great opportunities there that we don't have. For example, they have 28 days of paid governmental respite support. But we also saw their challenges were familiar to us. The loneliness of dementia, the stigma, workload issues, and workforce shortages, and some instances of poor data sharing. Throughout this whole project, we found they emphasized cultural awareness and made sure that they were addressing the needs of their entire society. So this primary care team was responsible for managing care, including prevention of falls, wandering, all the things that go along with dementia. They also help guide the family around the levels of care, provided this amazing caregiver support, helped with future planning, medication issues, and nutrition. So really, we identified 4 pathways for someone with dementia in New Zealand. Their hospital is much like our long-term care, and they do have dementia care units there. They also really try to keep the person at home with appropriate respite. They have rest homes, which are comparable to our assisted living facilities. Some are government run and some are private pay. They have day programs, and they also pay a lot of attention to the palliative care and hospice end of life for Alzheimer's disease. So that was New Zealand. So back to Vermont, working with a group including the health department, OneCare, a bunch of other players on developing this tool for diagnosing dementia in primary care using a smart phrase, which is something that if you have an electronic health record, you can populate your note with all the things that you really should be paying attention to. So this is primarily for primary care providers, nurse practitioners, PAs, physicians. And the early diagnosis and intervention really provides patients and families a good head start on this challenging disease. Appropriate specialist referral can be initiated as needed, but coming from the memory center, we know that there are a lot of instances that we don't need to see the patient. They can be managed in primary care. So let's start with a pre-visit. Now a lot of the components of the diagnosis actually happen during this Medicare annual wellness visit. There's pieces in that visit that can be brought into the diagnosis note. They include labs and screening. Also, we think that the pre-visit should include an informant interview that can be done by an LPN or nurse via telephone. So this is what the smart phrase looks like. Now, I've given you a handout. At first, you won't see any of these drop downs on the handout, but when you get past the first part, the second part of the document that I provide for you shows you all these drop downs. For example, the mode of onset. It gives a list of things that you can check off. So the subjective information includes the patient information, the informant information, alert factors, which I'll show you in a minute, and medication management. So this is the informant interview that is done by the LPN or the nurse with a spouse, a family member, or a caregiver. Now, these are the alert factors, and we took these right from the New Zealand pathway. So these are all things that we want to make very certain we are aware of at the time of diagnosis. This also assists in identifying resources for the patient and the family. So that was the alert factors. And medication management, of course, is so important when you're diagnosing dementia. So the objective starts with a cognitive screening. We are proposing the use of the Vermont Mini-Cog, which the SASH program in Vermont is already using. These are the red flags that we want to make sure in the objective exam are not missed. And all these things bring in assessments that can already be done. Uh-oh, I went too fast. Okay, assessments that can already be done, like depression, anxiety, substance abuse, alcohol abuse, and all the labs. See, this is the great thing about electronic health record. If you put that little @ sign and that lab has been done, that brings it right into your note. So all those are there. And then here is the physical exam, the physical assessment. And here is the assessment. So the primary care provider would choose one of these things. This doesn't choose it for them. It's not an algorithm, but they're all listed so they can be chosen. And then as far as the plan, do we need future testing? Do we need a CT scan at that point? Anything else, syphilis, HIV, all those things. Then we really have to consider, the driving evaluation, and next here, the medications that can be prescribed. So they're all listed out for a provider, and referrals that could be made at this time. And lastly, this is my favorite part, the resources. So this gives, was set up for Chittenden County. So this gives all the resources in Chittenden County. Now, lastly, I want to say that I went through that very quickly, but if you want a shareable video presentation, Lisa Vautier made one, and you'll have these slides. You can click on that and go to that and hear it all over again. Or you can email me. If you're not in the EPIC system, we have one primary care provider in Rutland who's working with their tech people to get their system set up like this. So it's a relatively easy thing to get a smart phrase set up. So I'm going to hand it over to Anne Marie. I'll stop sharing my screen right now. And okay, there we go.
Thank you. And now I need to figure out how to show. It will not let me share. It says you cannot start screen share while the other participant is sharing.
Anne Marie, I have it all queued up for you, so you just say.
Oh, wonderful. Okay, so we'll just go from there. Perfect.
Yep.
All right. So I just kind of jumping off the last presentation, very similar. I've been working the last year looking at a lot of different international type approaches, and having worked in the medical center, a lot of these I've been integrating into my own practice. So I'm going to try and do in a very short period of time some of what I've looked at and give you some examples, and then just how I've used some of these in my own practice. So, if you want to just go to the next slide. So in general, we tend to combine dementia care to just one plane. We think of it in a very finite fashion, when really it is something that impacts people across many facets of their life and across all of the care that they receive either in the community or even in the medical field. So some of the themes that we tend to see in international areas around systems. It's a more systemic approach versus a medical only approach. A lot of the interventions tend to really look at the person within the environment that they're living with, and how are they navigating that environment. Very different in rural versus urban settings, in a community where there's a lot of family versus people that don't have those resources available. Their focus around education along all aspects of the continuum of care, again, not just living in one place, but within the community, with dental offices, home, in the grocery store. It's across every aspect of where that client may be interacting. A very holistic approach, focused on not just the medical treatment again, but those non-pharmacological interventions that we can use to help support clients within their settings, which sometimes can be even more effective because we're not having to worry about side effects. And person-centered, looking at things that are how is this dementia impacting this specific person, but also who were they before? And how does that impact their process, how they move through this disease as it progresses. And then also a lot of empowerment focus. I see a lot of what we do in the States, and I think there's some shift that's happening, but a lot of it is focused on caregiving, and more what I'm seeing internationally is this focus around empowering the person with dementia and that shared decision making. So really trying to get them involved and helping support them to shift and shape how we do policy and how we provide care. So next slide. So I organized these rather loosely, and there is a handout that has links to almost everything that I have here. So if you want to go in more depth, you can actually go and look at it a little bit closer. So certainly stigmas is one of the biggest ones that we see. And again, that person-centered care. So a big theme I've heard is, I have dementia, I'm still me. And so there's a lot of videos and material that's being put out just trying to shift how we view dementia, not just looking at it in the late stages, but across the entire continuum. And I think also demonstrating how people in the early stages can still be productive and engaged and do a lot of the same things that they did before with a little extra support. So in Australia, there are some wonderful dementia language guidelines around how do we talk about people. And how do we share information as well. So it's that person-centered around, I'm not going to talk about, oh, he's the Alzheimer's patient, but it's the client who has Alzheimer's. I'm also going to be aware of, it may not be a caregiver, but a care partner. Because early in the disease process, you're not giving me care, but you're partnering with me, you're offering support. You're my consultant when I run into issues. And then in terms of language, how do we phrase things? I'm giving information to my client or to my patient. How can I change the language in those documents that's more digestible so that they still can have control over some of their care? There's a lot of programs being offered around different specialty areas. So LGBT, indigenous populations, clients who may be homeless. And the early onset, which I find is a very different process for my clients who are in their 40s, 50s, and early 60s versus my ones who are in their 70s and 80s. So Australia has a really great program. It's called the Key Worker Program, which is really almost like a case manager to help those early onset because they don't fall into other buckets. There's a TOPS program, which is kind of the This Is Me program out of the United Kingdom is very similar, where it's how do I share information about myself that you might find helpful when you're trying to offer me support. The Colton Care Risk Assessment tool is one where we can assess risk for activities. So we tend to be very care avoidant when we work with people who have dementia. We don't want anything to happen. We don't want them to fall. We don't want, there's a lot of risk involved. They may not have insight. They may not have the ability. But then what are we taking away at the same time? So, are we now diminishing their quality of life because they can't do some of the activities that they did before? So this is actually a standardized tool that you can go through as a team. It would be the caregiver, possibly the person with dementia, and whoever else is involved. And you would work through what you're looking at. So I think one of the examples was a gentleman who wanted to ride a motorcycle, and that was part of who he was. Well, am I going to just throw him on a motorcycle? Probably not. But I could probably put him in a motorcycle in a sidecar. And is there still some risk? Yep. Are we willing to take that risk? They were. But they were also able to have a clear documentation as to the process that they went through to make that decision. So it's really kind of balancing what the quality of life is versus the risk that we might look at. Barbara's story is a wonderful training. It's incredible videos. It's out of the Health Innovation Network out of the UK. You can find it online. They even have discussion protocols that go along with it. And it really is around increasing awareness of what the experience of someone with dementia might be in typical settings throughout the disease process. I found it to be incredibly powerful. So I strongly, strongly encourage you to check it out. The feedback from people that have gone through that, it's provided to staff in hospitals and medical settings, has been just very eye-opening. So it's really powerful, and I think it was incredibly well done. And then Canada has the PIECES tools for kind of figuring out when there's behavior issues, reframing it more around that they're having distress and how do we define that distress. Next slide. So the next one is really around that empowerment and advocacy. So again, huge theme, nothing about us without us. So we need to be involved. This is our care. We should be able to really guide our own care. So out of the UK, we've got the dementia statements. There's a deep guide for writing dementia-friendly information. And there's even a guide for people with dementia that is given to them, not to the caregiver, but to them in terms of what's going on with their own process. And then Dementia Voice is a really wonderful group working around meeting resources. So if you're working with people with dementia and you want their feedback, it's simple little tools that you can use to help them stay engaged, to help support them in including them. Scotland has a wonderful group. It's called Through Our Eyes. It's a CD that goes through and basically people talk about what their experience is within a life with dementia. And Australia has a wonderful project called Engage, Enable, Empowerment Project for people with dementia. And then lastly, the Dementia Alliance International, who has amazing videos on YouTube where people are talking about their experience with stigma, with people saying, you know, you don't look like someone with dementia, or you go into a hospital and they say, well, you don't have it. And some of their frustrations with that and what they would like as people living with dementia in a variety of, and this is all over the world. You're seeing the same themes internationally. Next slide. And then within the environment and community, Ireland, we have the Memory Resource Room, which is a crystal project. It's basically information and resources for people with dementia and their care partners. Dementia Friends, which I am seeing in the US. Canada has a Driving a Dementia Toolkit, which physicians can use to help figure out what their next steps may be in terms of addressing driving, which I know from my experience has always been a very difficult piece to kind of navigate. Wonderful resources for first responders. Australia has men's sheds for men who still want to use power tools and build things to help support one another. They use the Montessori method. They've got a wonderful online dental training for dentists. WHO has some wonderful information around using technology for support. Scotland actually has a book that was written by a woman with Alzheimer's disease around her experience with sensory challenges that she said no one ever told me was part of it. I just knew as a memory disorder. I didn't realize it would impact my sensory. And the UK has some really wonderful resources around sensory rooms, which can be used at home as well as in facilities. Next slide. So I won't, I'm now kind of coming up on time here. So in terms of integrated care, it's really kind of looking at that, again, that systems approach. From the time the person gets the diagnosis to the time that they transition into hospice, how do we help move them through that system in a way that, you know, when they go from the VNA to the hospital to the rehab center to home care to nursing home or assisted living, that we're helping support them through every transition that happens. You know, kind of looking at shared language. When I find so often we use language, but it has different meanings for all of us. So how do we make sure that we're all speaking the same language? So when I say to you, you know, this client is, you know, mid-stage, you know, what does that mean to you versus what it means to me? When I worked in a medical unit, someone would say, oh, they have an ejection fracture, blah, 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 blah. We all knew what that meant. You know, we don't have that shared language with dementia. I think that really impacts our ability to move people through the system. Standardized assessments are another one. I love the fact about, you know, in talking about pathways, if I come in for a stroke, there's a pathway. There's no pathways when people get diagnosed with dementia. And so there's this wide variety of care that is provided with lots of gaps. So the more we can standardize that and have that team approach, it really helps to enhance care. And then it also helps in terms of handoff. So and again, increasing recognition and engagement, making sure people were thinking differently about dementia, that we're really thinking in a strengths-based, person-centered approach, making sure that we're educating not just within the medical field, but also throughout the entire community, because sometimes that's where we're seeing the deficits, not when they pull themselves together in a doctor's office appointment. Looking at that early detection, engaging care partners early so that it's less stigmatized, identifying care teams across all systems and looking at ways that we can help facilitate that communication across those different pathways. Treating the disease process, looking at behavioral and psychological problems, and again, offering those supports. I always think counseling for both the person and their care partner is so important. really accounting for dementia in all the clinical decisions. And again, really partnering with those care partners there, making sure that they're part of the process. And then again, looking at those care coordination transition process and making sure that information is accessible. So hopefully some of that was helpful. If I do have more stuff, but it was a lot, so I'm not going to inundate, but I just wanted to kind of give a glance of what some of the things I was seeing.
Well, thanks to you both. Really interesting stuff. And so now we do have a little bit of